So this is the second of two videos on reflection in appraisal for GPs, and this one covers putting some of the models explained previously into practice, so looks at 3 case reviews and how reflection can be developed in them. But we start off with a quick recap of one of the models. So in the previous video we considered some models, all of which had 3 components to them. There's the what, so what, now what, which can also be described as the describe, analyse and action, or using the acronyms I've created, heat, detach and move. And these are captured in the next slide. So this slide goes through the 3 stages of reflection and the components that I've created the acronym to help us remember. So heat was around what happened, emotions, actions and thoughts. Detach is deciding what was good and bad, experiences. Time, alternative and choices. And move was mastery, outcomes and viewpoint. For more details about this, please refer to my first video in this 2-part series. We also looked in the previous video at how to grade reflection, starting at a simple description of an event, then with added interpretation, then recognising that something's important but not being able to explain why, at a higher level describing feelings, attitudes, beliefs, questioning and comparing. At a higher level there's judgment of what went well and what went less well and why, and at the highest level there's a change towards the future in relation to similar events, and there's an explanation in the context of references or resources. So now for the practical examples, we're going to go through 3 case reviews and illustrate how the reflection can be developed within each one. So let's look at this case of a patient with a chest infection who's admitted and suffers a VF arrest. I'll give you a minute or two to read the details here. So let's look at what elements of reflection are present here. Well, there's a sequence of events which is described reasonably clearly. It's reasonably clear why this case was chosen. It's unusual. There's been an arrest in a case that was otherwise a not uncommon clinical scenario to see in the community. There's a recognition of emotions behind it, so he's recognising that he was surprised that an arrest could happen in somebody where there were so few signs the day before. There's a degree of reflection going forward about his beliefs and how this experience has reinforced his beliefs, needing to believe his own judgment as a doctor even when challenged. And there's also some reflections about about his decision making regarding the threshold for safety netting and for admission. So let's see what else might be explored in the discussion in the appraisal for this case. So the first thing that strikes me is that there's relatively little detail of examination findings here, and that he also refers to there being few signs of apparent myocarditis, which could have helped foresee the need for admission and the likelihood of a VF arrest. I'm wondering how he made the decision to admit the patient, whether it was based on a subjective impression of severity of illness or whether it was based on any objective criteria such as the new sepsis criteria or the community acquired pneumonia guidelines from NICE. I'm also struck by the mention of him being challenged and wondering about the emotional impact of this and whether he ever perceives that being challenged can be a positive thing, and how it was that he dealt with the challenge, whether there was a valid alternative viewpoint there. So a possible development in the 3rd step in the reflective model in terms of so what might be at a learning level. I am now familiar with the NICE community acquired pneumonia guidelines and with a new score for sepsis and thresholds for admission. I've also read around cardiomyocytis signs and symptoms. In terms of outcomes for future changes, I will record full vital observations, carry out news score and explain the basis of decisions to paramedics. From the viewpoint part of this move section, it may be that on occasions a second opinion will be beneficial to patient outcome. For example, may know of local alternatives to admission, even if it wasn't useful on this occasion. And even where my decision is appropriate, it's important still for a team leader and clinician to be able to influence, listen and persuade colleagues of a course of action. So let's have a look at this case review. This is a healthcare assistant who came in with an ankle injury and at the end of the consultation mentions a potential UTI. She's prescribed trimethoprim, and then the following week when she sees another doctor, it's revealed that she was pregnant and that this predated her last appointment with the appraisee. So she's been prescribed an inappropriate antibiotic in the first trimester. Have a read of the rest of the case review. So let's have a look at what reflections are going on here. So the appraisee has gone up to the level of judging what went well and what could have done better, which is good. And he's also got a learning point moving forward, which is to ensure that he checks about pregnancy in childbearing women before prescribing for urinary tract infections or any medications. So let's see what else might be uncovered through a discussion of this in an appraisal. So first thing that strikes me is that the patient is a healthcare assistant, and I wonder whether this in any way influenced the doctor's behaviour. In particular, sometimes we make assumptions that healthcare professionals will disclose what's important and don't need to be prompted to do so. The fact that the UTI was disclosed at the end of the consultation makes me wonder whether this influenced the doctor, and the doctor might have felt rushed at the end. There's also reference to guidelines informing his decision. However, the treatment of UTI, the length of the treatment depends on a number of factors, i.e. whether it's complicated and uncomplicated and whether the patient's pregnant. So it's surprising that in referring to guidelines he hasn't thought to ask about pregnancy. There was also the fact that she was informed about the risk of trimethoprim and about the error by another doctor, and I'm wondering how that made the appraisee feel. And finally, it's interesting that the appraisee didn't ring the patient to apologise, and I'm wondering if that was a deliberate decision or whether that was due to lack of awareness about the duty of candour. So let's look at what might be included in the final stage of reflection here in the so what, action or move, mastery, outcomes and viewpoint. So under mastery there might be some learning around guidelines and the length of complicated and uncomplicated UTI and the importance of asking about pregnancy. There might be some learning around the duty of candour. In terms of outcomes, possibly a change in consultation style around agenda setting to avoid surprises at the end, and also a change in practice in terms of contacting the patient to explain and apologise for any errors. And in terms of a viewpoint, an awareness that treating a health professional can affect your judgment subconsciously, and that it's important, even when treating health professionals, to follow all the usual procedures. So let's look at our third and final case. This is a case of a palliative care patient who, although having an emergency healthcare plan indicating a wish to die at home, ended up dying in hospital. I'll let you have a read of the case and the learning outcomes and actions. So let's have a look at what reflection is going on here. So first of all, I'm struck by the choice of this case review. This was a patient for whom there was a care plan in place for a death at home, but where the patient ended up dying in hospital. So this is very worthy of reflection and discussion. Secondly, I note that the doctor was personally involved with putting in place an emergency healthcare plan, but that somehow that plan wasn't followed in the end. The doctor's also aware that there's a difference of perspective between the patient's wish to die at home and the family's wish to die at home. He's also showing that he can see that there's been a potentially breakdown in communication here between other members of his team and himself in terms of feedback to him as the usual doctor. And I wonder how he felt about that. He's also recognising potential feelings and viewpoints of his colleagues, so that his colleagues perhaps didn't feed back about these contacts with the palliative care patient because they didn't want to be seen as passing work over. So he's showing some insight into differing viewpoints and differing feelings. And finally, there's an action going forward about encouraging his colleagues to liaise with him when they review patients that he's the usual doctor for. So looking at this and discussing it further, in the context of an appraisal, I'm struck by this opening description that it's a long-standing palliative care patient. So it makes me wonder how the doctor felt about his death occurring in hospital, because this was a patient that he'd clearly had a long-standing involvement with, and he might have feelings of failure because of the final place of death. The other thing that strikes me here is when the patient was admitted, whether the doctor became aware of the admission at that point, and whether there were any discussions had between the GP and the hospital physicians about the final stages of palliative care, and how it is that the patient's wishes in the EHCP were not followed in the end. Makes me wonder whether there's been any discussions with members of the hospital team as well, whether there's been any discussions with the district nurses and the Macmillan nurse and the wider team. I'm also interested in this comment about no feedback to me as the usual doctor, and I'm wondering whether there's any explicit protocol in place about liaising with the usual doctor after ad hoc reviews by other members of the team, and also whether there's any system for scheduled reviews of palliative care patients. It's interesting that these reviews by other GPs were at the request of the district nurse, so rather than what appear to be scheduled palliative care reviews. So let's look at what learning could come in the final stage of reflection in the so what, or actions, or move, mastery, outcomes and viewpoint. So in terms of learning, there might have been some learning around the factors that contribute to the place of death being different to the one in the care plan. In terms of outcomes, there might have been a decision to formalise feedback processes between the doctors about palliative care patients to the usual doctor, and also from the Macmillan nurse. And there might be a plan to revisit discussions about the place of death with the family regularly, particularly if the family is less comfortable with the plan of having the place of death as the patient's home. It might be an action going forward to discuss the deaths in the wider palliative care team. And finally, there might be a change of perspective in terms of having scheduled reviews for palliative care rather than reactive reviews. Thank you for watching my video. I hope it's been helpful. Do send me your feedback to my NHSnet address, and feel free to share it with colleagues. You can also follow me on Twitter or watch other relevant videos on my YouTube channel.